was at a meeting recently where it was at a table surrounded by a bunch of very impressive, intimidating people, and everybody had to introduce themselves. And one of the professor of geriatrics admitted to feeling imposter syndrome, that when you don't recognize yourself in the description that's given, until you kind of go, oh yeah, I did do those things, but they don't all seem part of your current day-to-day routine, so you can actually forget some of them, and how you have ended up where you are. So I'm going to talk a little bit today about some new concepts in pain, both in terms of mechanisms and in its management. I've been in full-time pediatrics for the last 6 years or so. So this is mostly going to be through the lens of pediatric practice. I'm never quite sure where to pitch it in terms of focusing on molecules or focusing on more practical stuff, but I've hopefully left plenty of time for questions at the end, so if there is any particular area that people would like to ask about, then please feel free. Start with disclosures. I do some consulting for which I will someday get paid for pediatric pain trials in Europe. In the interest of full and honest disclosure, I may have reused some of these slides, so the aesthetic might be a little bit different from one to another. I've definitely reused some of these metaphors, and because I'm originally from Cork, I will probably speed up as I talk, and in all likelihood we will finish early. So, what is pain? What is the purpose that pain serves? I'd like to, at this point, refer to one of my favourite songwriters and poets, Leonard Cohen, who wrote that scars are the world made flesh. And the corollary where pain is concerned is that in many respects, pain is the world made real. That it's only when we experience pain or discomfort of some kind that we become fully aware and fully present in the physical world. The purpose of pain, or what pain actually is as a sensation, the fibers, the nociceptors that transmit pain are firing all the time, no matter what you're doing, walking, sitting, eating, these are continually firing, but at a level or at a threshold that doesn't produce pain or doesn't produce discomfort. So we're constantly sensing pressure, changes in pH, changes in temperature, but not at a level or not at a threshold whereby it produces pain or discomfort. And it is only when we feel discomfort that we perceive that as a painful stimulus, and that, as we'll see, that then prompts us to take some action in response. One of the questions I'm very fond of asking in the kids in my clinic is, some of whom have experienced pain for quite some time, is whether pain is a good thing or a bad thing. A surprising number of them, because I have a feeling that they're all talking to each other in some Facebook group, are now answering that, well, actually, yes, pain is a good thing, because pain keeps us safe. If we did not feel pain, then we would not live very long. There are some families around the world, some children around the world, who are born with genetic conditions whereby they do not experience pain, and they may live until their teenage years and occasionally into their 20s, because they will break bones, they will injure themselves, burn themselves, they will get appendicitis, all manner of things will happen to them, but because they don't perceive the threat, they cannot respond to it, and therefore they suffer the consequences of it. So a surprising number of kids seem to be aware. I don't know from where, whether they are all talking to each other, but do seem to be, which is very encouraging to me, and it cuts about 15 minutes of explanation out of the consultation. Seem to be getting this concept that pain is actually a good thing. It is only when pain becomes chronic or persistent, when the link between the painful stimulus and the threat associated with it, when those are uncoupled, then that is when it becomes maladaptive and is no longer serving a protective purpose. Acute pain, I very often describe as a computer program that runs within our nervous systems. Kids in particular are very aware of electronics, phones, tablets, electronic analogies, a very easy way of communicating pain transmission within the body. But we are not computers. We are not tablets or phones, and there's a lot more to our consciousness and our sensory experience than purely nociception. But very often it can be a helpful way of starting that conversation. Acute pain is a very simple program. It very simply communicates, and as it was intended to, location and quality. So it will, for example, tell you that you have a pain in your leg. It will tell you whether that's an aching pain, a burning pain, and the transmission of that pain up through the spinal cord, synapsing at the thalamus, and then to the cortex is relatively straightforward and relatively linear. So a 4 out of 10 pain or tissue injury that would produce a 4 out of 10 pain in the leg is still perceived as a 4 out of 10 pain in the brain. Where things get a little bit more complex is in complex or chronic or persistent pain, where the relationship between tissue injury and the pain that's perceived is uncoupled. And this can happen for a multitude of reasons, but the way in which pain is now perceived and the pathways involved, the synapses that become involved, are different and more complex. Very often, once pain has continued for some time, it is no longer perceived in only one location. You start perceiving pain in multiple locations, even though there isn't necessarily tissue injury in multiple locations. Very often, this pain will now also have some neuropathic features as well. So burning, it will be described as a burning or shooting or stabbing pain. What also happens is that it's no longer a straightforward linear transmission along a pain pathway, a traditional pain pathway. It's now branching off and synapsing with other thalamocortical pathways and involving other other regions within the brain. So it is processed and perceived in a different way. Once pain has persisted for some time, patients will very often start to worry about the underlying cause, if additional tests need to be done, if there is some other sinister cause for this pain or other explanation that has yet to be accounted for. As it also progresses, the limbic system becomes involved, the emotional processing circuitry becomes involved, and pain is described in much more emotive language. It is no longer, ow, it's a 4 out of 10 pain, it's sharp, it's in my little finger. It's now a 6 or 8 or 10 out of 10 pain, it's still in my finger, it's now in my elbow, it's also my shoulder. Why is this happening to me? Mary down the road had a similar pain, she ended up having cancer, or she had, my uncle had a similar pain, he had a heart attack. The different synapses become involved, different pathways become involved, and the perception of the pain becomes far more enmeshed in emotional circuitry. The challenge with complex pain, unlike acute pain, we try and reduce the pain and then improve your function. For complex pain, what we need to try and do is improve your function at the same level of pain, and it is by improving your function that we reduce your pain. So it's ultimately, and at the risk of sounding like Dr. Phil or Oprah, complex pain is an opportunity for growth and development, and it's only through growth and development that you will actually achieve a reduction in pain. Everybody loves a bit of taxonomy and a nice classification system at 8 in the morning. But this is something that's now filtering through to how we categorize pain, how we will end up categorizing, classifying, and sifting pain into different categories and treating them then accordingly. We're starting to see a move away from a focus solely on pain intensity as the primary outcome. That is something that was initially necessary in the 90s when pain became the fifth vital sign, and it was necessary for clinicians and for the public to start recognizing and treating pain appropriately. But unfortunately, one unintended consequence of that was that it led to situations like the opioid epidemic in the US, that if at all costs pain must be less than 4 out of 10 for someone to leave hospital, or for your institution to get accredited that you always treat pain or manage pain and target a particular score, and you do not get accredited and therefore don't get paid, then you will achieve a pain score of less than 4 out of 10 at all costs. And that's something that had led to the explosion in the use of opioids inappropriately for non-malignant pain. So now that unfortunately the genie is out of the bottle, there's been an attempt to approach pain management in a much more holistic manner. That it's not just a unidimensional focus on pain intensity, but to take other axes or other dimensions, or take the context of pain into account as well. This is something that had originated with managing chronic or complex pain, and is now being reverse engineered to the treatment of acute pain as well. This is out this month in Pain Medicine, where the American Pain Society and other groups have met to try and classify different acute pain conditions, sift them into categories, and therefore develop treatment algorithms and research themes around the different categories. One of the most striking changes has been the attempt to rework or redefine acute pain, and certainly I'll have to admit I like this because it rhymes with what I say myself, but that the purpose of pain is to produce a response. It's to produce movement. So and this is something that underpins the transition from acute pain or a multiple acute pain events to more chronic or persistent pain. The purpose of acute pain is to get you to move, to do something. If you sit in a seat for too long in one position, if you lean on one butt cheek for too long, you will start to feel pressure, you will start to feel uncomfortable, and that will prompt you to move. You will shift and change position, and it is in changing position that you will relieve the pain. If you put your hand on a hot cooker, you will pretty quickly move your hand away. It is the purpose of pain is to produce an action. If you don't, you will very quickly get wind up, central sensitization, other changes in how that pain is processed within the spinal cord and within the brain, and your brain starts ramping up the volume on that pain signal. So sometimes a single episode of acute pain, very often it is multiple episodes of acute pain that don't produce the desired response, that don't produce a response that terminates the pain, will very quickly lead to changes within the central nervous system that turn up the volume on the pain, and therefore all future pain is perceived as more painful. And this is from the same article from that review group, whereas we now, in addition to approaching chronic or complex pain with a multi-dimensional approach, that we also start applying a similar approach to acute pain, that we don't simply just focus on pain intensity, but also look at other features, pain trajectories, look at other potential positive and negative modulating factors, such as socio-demographic, biopsychosocial and surgical factors, or positive and negative factors that might turn up the volume on an acute pain signal or dampen down the pain signal. And ultimately, what is the impact on function? What is it that a person can or cannot do as a consequence of pain? And these have been proposed as as the categories into which acute pain should be sifted: surgical and procedural, and non-surgical. One of the other changes in our understanding of pain relates to the underlying biological mechanisms. Labour pain has always been held or used as a reference point for an intense acute pain. It's the pain in labour that is perhaps the most intense pain that a normal, healthy human female might perceive. For a long time, we did not understand why labour pain was as painful as it is, and thankfully, with modern neuroimaging techniques, staining techniques, and shifting the focus slightly and starting to look for different mediators that might underpin the intensity of this acute pain, a picture is starting to emerge that even something like labour pain that serves a social purpose. Why do human females, apart from being punished by God, but why do human females perceive labour as painfully as they do? Not other species do. However, it must serve some protective or some physiological purpose. It must do something for it to have persisted within our species for as long as it has. Human deliveries, human infants are relatively large, relatively complex. Human delivery of a human infant is not without risk. The pain, maybe it doesn't need to be quite as intense as it allegedly is. But it makes the labouring mother seek help. It completely disrupts her routine. She has to go and find a quiet, safe place to deliver. There is absolutely no alternative for her but to do that. There's nothing else she can do. Pain is also a social contract, and we see this with my work as an anaesthetist. The louder the pain, the more that pain is expressed, the more people you bring to you. So we see that very often in a recovery. With children crying after surgery, the one who's crying the loudest, the one who's crying the most, has twice as many nurses around them as the one who's not expressing it in the same way. So that is the purpose of within a social context. That's the purpose of labour pain. That it makes the person seek a safe place to deliver, but that it also means that they get the help that they need, because very often you do need somebody else around to safely deliver a baby. So that's pain within a social context. Within a more physiological or biochemical context, what actually happens during pregnancy is that under the influence of estrogen, C fibers, the innervation of the uterus by C fibers increases exponentially. These C fibers express TRPV1 channels. These are heat-sensing ion channels, capsaicin, chili pepper, that perceive changes in pH and temperature and transmit pain. and that these are activated then during labour under the influence of cytokines. So that a picture is starting to emerge at a biochemical level as to why labour is as painful as it is. Does that make sense? I mentioned cytokines. Everyone, one of my favorite slides that I no longer use was the periodic table of cytokines, because I think it just induced this kind of pre-diarrhea feeling in most people that if you see 35 cytokines on a projection, trying to make sense of it isn't something most of us would voluntarily do. I did for a couple of years. I spent a few years studying the interactions between neurons and glia as they pertained to chronic back pain in adults. For most of the 20th century, all of our focus in terms of pain transmission has been on neurons and neuronal transmission. Neurons only make up 10% of cells within the central nervous system. The other 90% of cells within the central nervous system are what are called glial cells. So that's a bit like if you're looking at the whole body, if we'd only ever studied the skeleton, but never studied muscle, liver, lung, hearts, all of the other organs, all of the other things that go into making a human body. If we had only ever focused on the skeleton and not all of the other stuff, and yet that's what we did for 100 years or so when it came to studying pain and pain transmission. So in the last 15 years or so, there's been a shift towards studying the interactions between the glial cells, and these are immune cells that reside within the central nervous system, their interaction with neurons, and how that interaction between the two can lead to complex pain or persistent pain states. Very often this doesn't come out very well. It seems to be okay there. What we're building is a picture of traditional pain transmission. Acute pain, 3-order synapse starting in the periphery, ending up in the brain. That's what we refer to as nociceptive pain. That serves a protective purpose. Inflammatory pain is another form of physiological protective pain. So if you've got a persistent inflammation, then that is something that does also mean that a body or an organism will change its behavior in some way. So if you've got an appendicitis, you will lie down and you will take it easy until that inflammation is resolved one way or the other. Surgery and surgical pain and procedural pain is a mix of two things. At the time of surgery, scalpel in, the actual incision is a nociceptive pain, but the tissue response to all of the pain that you have for days and weeks after surgery is an inflammatory pain. So, if you are recovering from surgery, recovering from a procedure, you're taking it easy, you're minding yourself until it's only when that pain is resolved, that's the signal to you that you can resume full activities. Very often what we see though is the two types of pain on the right hand side which don't serve a protective purpose. This is neuropathic pain, and about a third of chronic pain presentations have some neuropathic component to them. And finally, functional pain. So this is central. This can encompass anything from fibromyalgia, functional abdominal pain, other functional pain disorders, where the pain isn't coming from the organ. The issue is something that arises de novo within the central nervous system. It is a central processing problem, not, they don't need more tests of bowel function. They don't need more investigations of the organ that the pain is coming from. That's just a manifestation of an issue with central pain processing. Waiting for time. One thing that I was going to present was some data from our clinic in Temple Street that I thought would be a nice way of underpinning the concept of pain as a biopsychosocial phenomenon, something that we all say a lot. I've been in enough MDTs with physios, occupational therapists, psychologists, nursing, or myself, where we all trot out the line, because we're good 21st century pain clinicians, and we say, well, obviously I manage pain within a biopsychosocial context, as though we deserve a little gold star for saying that. But what that simply means is that it's not just about the biological transmission of pain. There are psychological and social factors that can lead to either increased pain or decreased pain. In terms of biology, what we did was look at the first 12 months of our clinic in Temple Street, because we started that one before the one in Crumlin. And I think it was the first 80 patients that we saw in the first year. More girls than boys, and this is in keeping with international data, across most age groups, that women are affected more by chronic or complex pain than men, and that is related to underlying biology, to differences in gene expression, hormone levels, that unfortunately they are more at risk of developing a chronic or complex pain condition. For, let's say, fibromyalgia, for example, that affects 7 times more women than men. Interestingly, though, coming back to the point about hormones and endocrine influences on pain, that's something that only comes into play post-puberty. So before puberty, we see more boys than girls with chronic or complex pain, and it's only after puberty that it switches to more females and males affected by complex pain. And as you can hopefully see on the right-hand side as well, I think the mean or median age of the kids presenting to our clinic is around 13. The younger you are, the more protected you are from developing a chronic or complex pain condition. This is something we do see in practice. You very rarely see, let's say, for example, taking, from an oncological perspective, you very rarely see very young children who've had, perhaps, amputations for an osteosarcoma, chemotherapy, radiotherapy, you name it, in terms of their nervous system taking a hit. But we very, very rarely see chronic or complex pain or persistent pain of any kind under the age of 6. And only, which we didn't really understand why until quite recently, but in animal models, younger children produce a much stronger anti-inflammatory response that kicks in and dampens down the ongoing inflammatory response. So they get the same initial spike in inflammation. They still have the same risk factors, but due to differences in gene expression, that is dampened down in younger children. And it's only from the age of sort of 6 to 7 onwards that we start to see any kids with persistent pain. Looking at some of the psychological influences on pain, particularly when it comes to children, parents, something we say from time to time, sometimes jokingly, sometimes ruefully, that you don't get to choose your parents. And for some children, the difference between one child and another developing greater pain is the parental responses to the pain that they do have. One construct that has been explored quite a bit in terms of pain is that of catastrophizing. In a nutshell, I'm not a psychologist. I'm always wary about saying this in front of psychologists because I'm afraid of getting something thrown at me. But catastrophizing in a nutshell is how likely you are to make a big deal out of something. So how likely you are to magnify it, to ruminate on it, that you just get stuck and you make a bigger and bigger and bigger deal out of it. And there's actually a way of scoring that, and that's something we do with the kids that attend our service. And what we found is relationships between the estimates of so parents who are higher catastrophizers, more likely to freak out or make a big deal out of things, were more likely to on the bottom right, overestimate the amount of pain that their children had, and on the top right, they ranked their child's ability to cope as less. So unfortunately, that's something that does become a self-fulfilling prophecy. If a child is told, if a child perceives that this is something that they're not able to cope with, then lo and behold, they're not able to cope with it. So parental responses, parental psychological processes can have a very strong influence on the amount of pain that children experience. And this is something that was the idea of this research associate that we had, a research student for the summer, who wanted to take our demographic data and look at it in terms of access to services and the potential social influences on pain. She's now a dietitian in Temple Street. She's grown up and graduated and moved on. What she did was look at the deprivation index, and this is something that can be gathered from somebody's address. So you can look at average rates of car ownership, level of education, other different social indices, and correlate that with the number of patients that we were seeing in clinic. And what she found, which surprised us, was that we were seeing and it scored from 0 to 10, 0 being most affluent and 10 being most deprived, and found that we were seeing far more children from deprived areas than we were from more affluent areas. This is something that surprised us because our subjective experience was that we were seeing far more middle class children of overachieving children, over diaried, overcommitted, both parents in work, both parents who'd had third level education. That was our perception because those are the parents who keep ringing us, who stay on top of things, look for repeat appointments, say that's not working, what else, what next. What we're actually seeing with far more children from socially deprived areas, but we never hear from them because their dynamic, their relationship with healthcare is going to be different. Probably wrap up soon-ish, I think. So just very, very briefly going to speak about some of the changes in medication management for chronic pain that have arisen. I've already alluded to the opioid epidemic. I'll reference that briefly. One of the more interesting discoveries, I think, in the last couple of years is, well, certainly from a physical pain perspective, is that paracetamol, which is something we give buckets of to children and to anybody who's recovering from surgery, with the idea that it has an opioid-sparing effect. So it's something that was sort of, it had migrated over from acute pain services to chronic pain services, was the idea that taking round-the-clock paracetamol was something that helped and minimized the amount of other medications that you might need. And what's been found in a Cochrane review is that paracetamol, although widely used for back pain, being the one that was looked at, although being widely used, is largely ineffective. It does nothing. Effectively, it's placebo. It's good for relieving temperature, but for chronic or persistent pain, it basically does nothing. Interestingly, though, in the last couple of years, what various different research groups have been looking at, and again alluding to the way that different circuitry becomes involved within the central nervous system, is the effect on paracetamol on emotional pain and the ability to empathize, and the suggestion that taking paracetamol is good for heartbreak. Now, this is something that, so if you've had what my mum refers to a romantic disappointment, that taking paracetamol might blunt the pain of that. This actually led to NHS England issuing advice, please don't take paracetamol, if you've been dumped. You're still exposing yourself to the risks of liver injury and so and also because of the risk of someone in a heightened emotional state. I think they were concerned that someone might unintentionally overdose. But that the other circuitry that becomes involved in pain may be affected by the drugs that we administer. The downside, though, of paracetamol, before you all rush out for, if someone, if you do experience some rejection or disappointment, it does also blunt positive emotions. So it has appears to have an overall numbing effect in terms of emotional affect, that people become just far less expressive, and it blunts the positive as well as the negative. This turned up in my Facebook feed yesterday. So this is from a headline from yesterday's Economist, because I'm that much of a nerd. I have updates from The Economist on Facebook. But this is where things are going, or I think is a warning of the direction that things are taking, because the opioid epidemic in the US has become a public healthcare crisis, and there are a lot of other factors, institutional factors, systemic factors, that led to the ridiculously widespread prescribing and of inappropriate prescribing of opioids. That as part of the pendulum swinging back the other way is the suggestion now that if you prescribe opioids, you're a bad doctor, and I think it's going to be interesting times. For if you're thinking back to 40 or 50 years ago, the use of opioids in a palliative care setting was something that was very difficult to get patients' families to agree to, because it was was perceived as almost as euthanasia, as it would precipitate, it would hurry things along. And now, because of the issues that have arisen with opioids in non-malignant pain, this is information that's going to be out there in the ether and available to people. And I think there is going to be a great deal more difficulty in terms of managing pain where opioids would be appropriate, unfortunately. I mostly, in my practice, prescribe buprenorphine. It's my favorite opioid. It's a mu agonist kappa antagonist. Several advantages to it because of the kappa antagonism. You don't get the respiratory depression. Also, because of the kappa antagonism, you don't get the same issues with dependence that you do with the others. So you're not necessarily, it's like having a little bit of naloxone built in there, like you do with Targan. Because of that degree of antagonism, you're hopefully achieving a sweet spot where you're still getting the analgesia, but not needing to keep increasing the doses to achieve the same effect. And one of the other, there's emerging evidence as well for buprenorphine that it does also have some role in peripheral neuropathic pain. So may also help with some of the neuropathic components to pain, in addition to the sort of the nociceptive or inflammatory component. I'm on the data monitoring committee for a trial of looking at gabapentin in pediatric pain. Gabapentin and pregabalin are not, I'd like to hear what it's like in adult practice, are not without risk and not without side effects in children and particularly in adolescents. All anti-epileptics are associated with an increase in suicidal ideation, and we found that particularly with teenagers who perhaps have been started on gabapentin elsewhere, and on a rapidly increasing dose can very quickly develop changes in behavior, in suicidal ideation, self-harming behavior, that necessitates inpatient admission. But then once you do, and you get the gabapentinoid off, that resolves pretty quickly. So I'm uneasy with prescribing gabapentinoids unless it's tied to a very different or very definite functional outcome. On that theme, just in relation to opioids, one of the big challenges we have is trying to get our own colleagues to give ketamine, the horse tranquilizer, the disco drug. It's a very good, safe analgesic. It is very often, once added to a multimodal package, has had a transformative effect on someone's pain. And the difficulty has been the convincing our own colleagues that we're not trying to make the child hallucinate, and that it's at appropriate doses, at low doses, you can achieve the analgesic effect without any of the psychotropic effects. This, in a nutshell, and I might make this my last slide, because unusually for me, I've actually not sped up as I've been talking. This, in a nutshell, or in one slide, encapsulates our approach to pain management in children. It's a multimodal, multidisciplinary approach. The helpful acronym or way of remembering it for ourselves and for explaining it to children and families is the 3 Ps approach, or 4 Ps, depending on how pedantic you are: pharmacological, physical or physiological, and finally psychological pain management strategies. In terms of pharmacological strategies, because in chronic or persistent pain, it's not, if you target it in terms of monotherapy, very often you're not going to get anywhere, because they're by the time you're seeing somebody, they already have peripheral sensitization and central sensitization. They have a changed and altered peripheral sensory processing as well as a central one, and you have to target both. It can't be in either or. Peripherally, use a lot of topical lidocaine patches. Capsaicin can be very helpful for peripheral neuropathic pain. Most kids hate it. Don't know what it's like in adults. So capsaicin is a TRPV1 agonist. So we use topical menthol, which is similar to TRPM8 agonist, but there is cross-sensitization between the two. So it works ultimately on TRPV1 channels as well. Mary Fallon in Edinburgh, who's the professor of palliative care, as part of her research group, and they'd also discovered that topical menthol was also quite effective in patients with chemotherapy-induced peripheral neuropathy, and particularly for the cold allodynia associated with that. So I stole the idea from her and now I give it to kids. In terms of systemic analgesics then, we cycle through non-steroidals. Very often, if one non-steroidal is no longer effective, simply switching to another. can restore efficacy. We particularly like naproxen because of its long half-life. So twice daily dosing can be the difference between getting a full school day for a child versus only making it till lunchtime or making it till mid-afternoon. So particularly for somebody that we're trying to get back to school, we found the 12-hourly dosing with naproxen to be helpful. Clonidine, an alpha agonist. Magnesium, we give quite a bit of. It works at NMDA receptors, at TRPV1 channels. As taken orally, it also works as a laxative. So very often it's good at offsetting some of the side effects of, let's say, amitriptyline or of opioids as well. Vitamin C, we can give buckets of to kids because the main side effect that happens with supranormal doses of vitamin C is, and it particularly affects middle-aged men, is kidney stones. That you get hyperoxalate kidney stones. Kids don't, so we give them loads. This was something that was discovered in the prevention of complex regional pain syndrome. So postmenopausal women who were at risk of developing CRPS after a forearm surgery or forearm fracture, that by giving them vitamin C beforehand halved their risk of developing CRPS. And now it's finding its way into treating established pain, so osteoarthritis, post-herpetic neuralgia. It's also been found to have an analgesic effect. The thinking is that it acts as a cofactor for endogenous opioids. So it helps you use your own endogenous opioids more efficiently. In terms of antineuropathic meds, usually start with a tricyclic, usually amitriptyline, because it's an old, dirty drug. It works on about 15 different receptors. So rather than targeting one specific thing, trying that, increasing the dose, okay, that didn't work, try the next thing, try that, that works on a different receptor, increase the dose. You just blunderbuss approach. You give the thing that will, scattershot, hopefully work on as many different receptors as at once. And the other advantage with amitriptyline is the improvement in sleep quality. That I know this has been challenged more recently, but certainly when I was training, that amitriptyline is very effective for maintaining normal REM to non-REM ratios within sleep. Then, failing that, we might escalate to SNRIs, for SNRIs over SSRIs, because noradrenaline has been found to have had a greater role in pain transmission than serotonin. Gabapentinoids, already discussed, ketamine, and as a last resort, typically, because for the most part, we're seeing kids with non-malignant conditions, then we might resort to opioids, but only if it translates into an improvement in function. In terms of physiological strategies, psychological pain management strategies, it's as a holistic an approach as possible. There's a lot of education that we do. I won't go into the last two in great detail, but one of the concepts that we've borrowed from educational theory, learning theory, is that we're using is that of scaffolding, and that's one of the metaphors that we very often beat to death. That what we're doing is scaffolding. You put the scaffolding up before you start your renovation. The renovation, or the hard work that the child or young person is doing, is rehab, and is ultimately self-managing and being in control of their own therapy. Medications are the scaffolding. When you start doing that initially, it's going to be painful. It's going to be sore. It's going to be difficult. So what we're trying to achieve with medication is get you started on that process, and then as they become more confident in their own ability, and as they start doing more, they will start experiencing less pain, and find the other pieces of therapy easier to engage with. And ultimately, what we'd hope to do then is start scaling back. You start taking away the scaffolding once the renovation has been done. Was that we'd look to wean off as many medications as possible. You leave it there?